It's good to be back lecturing again this year. I know this is going to play on Friday, so I hope to see you guys tomorrow. I'm going to come down to Dearborn for the meeting, catch up with everybody, and I've recorded this a couple times already, and I keep going over, so I'm going to try to get through it fast. But I'm talking about the midfoot this year. Let me expand my. Okay, so there's our little COVID-19 that's keeping us apart for part of this conference again. What got me wanting to talk about the midfoot this year? And I know the guide for the program talked about arthritis, but this is a little bit more than just midfoot arthritis because I was going to be together with everyone. I was going to ask everybody a show of hands who orders MRIs, and I figured, everybody in the audience would raise their hand, but just for a little levity, I was going to ask who orders I'm not sure what the hell's going on RIs, because I'm sure a lot of us do this, and I do quite a bit in my practice because I have a lot of people that come in with kind of diffuse, non-specific midfoot pain, and I know you can't inject a cortisone near a tendon. So you've heard me lecture about sclerosing injections, and we strap and brace some of these cortisone where it's appropriate. I call it the PT punt, right? See in 6 weeks if you're still having problems, and you hope they don't come back because you had no idea what was going on, and then a number of them come back and they're not better. And so you maybe took x-rays before, and then you take another set, and there might be some arthritic changes, but nothing major. Like the level of the discomfort is well beyond what anything looks like on the x-rays. So then there's the eventual MRI, right? And some of these MRIs, they show multiple areas of pathology. They show joints that are edematous or arthritic, way too many to fuse typically, and some consistencies between MRIs that we're going to talk about. And some of these I want you to start, when you see these, maybe you'll start being clued off about what's going on with these patients. There's a lot of tenosynovitis going on too, with or without tears. And so we're going to talk about 5 of my patients here. I just have their initials up, but we're going to talk about these 5 patients. They're all, young to middle-aged females, and we're going to go through them. But before we talk, clearly the symptoms are, this kind of, in general, this diffuse midfoot pain, and nothing overtly on X-ray. And so we're going to talk about their MRIs, and we're going to start with KB on the top, and she's a 52-year-old female, and here's her MRI. Okay, and we're going to start looking at a couple things here, but I'm going to put a couple markers on the screen. The first thing she's got is, we're going to talk in general about the sections of the foot, but she's got some rear foot subtalar joint effusion going on. She's got a talonavicular ligament sprain. And once again, these people they're not athletes, they don't have any injuries. She's even got some chondral loss of the TN joint. We're going to talk about the TN joint. She's got lateral stuff going on, chondral loss of the calcaneocuboid joint. She's got, here's our midfoot, minimal 4th TMT arthritis, and she's got Lisfrank's multiple ligaments consistent with sprain. And once again, no injuries. Things that you wouldn't see typically that you'd find with just, happening because somebody has a little bit of an altered gait because of a problem going on. There's posterior heel things going on, Achilles tendonitis, okay? Spurring of the calcaneus. A lot of these people on their MRI, these patients, they'll have a thickening of the plantar fascia, whether they have fasciitis symptoms or not. They'll have a plantar spur. Here's one thing we're going to keep coming back to. There's atrophy of muscles. And I want you to start thinking about this. Here's another one. Edema of muscles and denervation, if I can go back one. But denervation of muscles. And you're like, what's going on with the nerves in some of these patients? And here's PT tendonitis, right? So, okay, could be a flat foot. Well, there's peroneal tendonitis too, sometimes with a tear, sometimes without a tear, but tenosynovitis, and thickening of the ligaments and issues with the lateral ligaments. Here's, on this one, there's a mild to moderate edema of the PTFL. We're all aware the PTFL is the strongest one laterally. Stuff's not supposed to happen to that one typically, right? No history of an ankle sprain with this patient. I'll go a little faster because we tagged everything on the first one, but once again, medial stuff going on. NC, and this one had moderate to severe arthritis. So there's one joint, but more medial stuff going on. TMT, first TMT chondral loss, second, third, fourth, and fifth arthritis at the TMT joints. Liz Frank's issues. Above this, talonavicular chondrolos, right above that, perineals we circled. Posterior tib. Here's an anterior tib. Edema of the foot muscles and denervation. Here's the middle patient. Now, she didn't have an MRI because she's got metal in her foot, but she's a 34-year-old attorney, and she knows exactly what's going on with her feet. Smart lady. Surgery bilaterally 20 years ago, and we'll get into this a little bit more, but her right foot's worse. She's got cramping, tightness. Both feet can give out diffuse, nonspecific midfoot pain, and we're going to get back to SB. Here's this fourth patient, MT. Look at this MRI. Sometimes I look at these, and I'm like, what are you going to have to fix with this? How long are you going to have to book the case for? Let's break this down. Spur planarly, fascial edema planarly, abductor digiti minimi and musculature denervation. You're seeing this again now, myositis, right? Achilles. Let's go to the next one. This is page 2, posterior tib. Above that, you can see fourth metatarsal cuboid arthritis, right? Mild to and here's one I didn't notice in the last dictation when I tried this first and I went over. Look 2 above that. Mild to moderate calcaneal eversion. Okay, this makes sense. She's got a flat foot, right? Here's anterior tib. Here's perineal tendon issues. Here's problems with the lateral ligaments. Well, wait a minute. If it's a pronated foot, you don't usually have issues with lateral ligaments unless you've had a sprain, and there's no sprain. Here's our edema in our foot muscles. This is in the impression. Denervation. You're seeing this again and again. Fibrosis of the lateral ligaments. Here's our last patient, BP. Talonavicular joint. Calcaneal spurring posteriorly. Edema of extensor brevis. Contusion, myositis, early denervation could be considered. What's going on? Perineal tendons. Lateral ligament issues. Okay. Let's start tying it together. Here's our 5 patients. There's clinical consistencies with all these patients. This is going to surprise you, but these people have an anterior cavus foot type. And they have Aquinas. And I need you to think about those 2 things for a moment and think about how an anterior cavus foot type functions and what would a superimposed contracted posterior muscle group cause to these patients. You all know that we're talking about the pesky midfoot here, and this is what I'm talking about. I'm talking about anterior cavus foot type where the forefoot is hyperdeclinated below the rear foot. We're going to talk a little bit about midfoot OA because these do get osteoarthritis, and this multisynovitic MRI, and you just saw 4 of them with problems all over. You all know how I feel about Aquinas, right? I hate Aquinas. I want to rid the world of Aquinas. I've spoken about the Baumann gastroc recession, which is one of my favorites to do. I do a bunch of them every year. And here's this cavus foot type. Look at that for just a minute and think about that foot. I had a sip of coffee. How do these feet function? Well, you remember what pseudo-Aquinas is, right? You have to burn ankle dorsiflexion to get that forefoot back up to basically to the ground. And then you start locomotion. Then we need 5 to 7 more, which I still think is bogus. I think you need more than that, but let's just go by the old idiom of 5 to 7. What if you don't have it? What happens? Here's that anterior cavus foot rocking back, and now maybe you don't have any more ankle motion, right? Here's that foot. Well, if you can't bend well here, where do you end up stressing? Well, look at the peak of where this arch is. I call that the midfoot, right? That intersection. PT somewhere around there. Peroneus brevis is somewhere around there. Here's the overlay of the skeleton. Is it making sense now what we saw in those 4 MRIs? It's all in this area. Posterior and plantar calcaneal spurs indicate a short tendon. I know my very good buddy John Harris, I hope he's listening right now, but a couple years ago at a lecture, John doesn't get x-rays of his heel pain, and I told him I asked him, what if there's a cyst, and he gave me it would be different pain, and that's true, if there's a UBC or an ABC in the calcaneus. But here's the thing, posterior and plantar calcaneal spurs to me on the x-ray tell me a story about what's going on with this foot. Here's our 5 patients again. You know, we had stuff on these MRIs, posterior tibial tendon dysfunction and midfoot arthritis and all the kind of things that you see with a hyperpronated forefoot, right? And here's KB. Here's her x-ray. Look. That's a cavus foot, folks, right? Plantar calcaneal spur, little posterior calcaneal spur. It's interesting, these people, when they get on the orthoposer, they can't their leg back. They have kind of a negative angle because they don't want to stand with their forefoot, with their ankle, you know, at 90 degrees because it's less comfortable. Look for 1 second at the anterior aspect of that ankle joint because we're going to come back to this. Look what's happening. See that compression at the anterior ankle joint? We're going to go back to that. There's an interesting finding that I want to talk about. But see the little bit of irregularity at the TN joint? We're going to talk about that too. Let's look at JB. Here's her lateral. I'd still call that a cavus foot, right? Look at that posterior calcaneal spur. Look where the peak is. This is the one that had the severe arthritis at the at the NC joint. You know, from the lateral, I know those X's are up there, but it doesn't look severe. Here's her foot. It's anterior cavus. Here's her MRI again, one real quick. This was the severe NC. Here's her AP. Now, I'd maybe call that moderate arthritis at the NC, medial NC joint, but look at her MRI. Look at the edema within those bones. And we're going to get back to this because these MRIs are picking up on strain that is in areas that are not clinically symptomatic. Now, she's symptomatic here. This is one of the reasons why she got this. She has pain in the anteromedial foot. Let's take those away. Look at that TN joint again. I'm going to come back to that again. Let's skip over SB for a second. Here's MT. Here's that 4-page MRI. Here's her foot. Posterior plantar calcaneal spur. Look at the TN joint again. Going to come back to that. Let's look at BP. You're seeing something over and over again here, right? Look at that canted leg on her lateral. We tell them to stand straight up, and then you walk around the corner to take the x-ray, and this is where they position themselves. Keep your eye out for these subtle signs on the MRI. There's denervation. There's no clinical signs of tarsal tunnel. There's this lateral ligament pathology, which I would expect with a cavus foot, but there's no history of ankle sprain. None of these women. Muscle edema and a multi-synovitic MRI. What's going on with these? Here's the 4-page. This is MT again. Do you know what her primary complaint was? What would you think when you've got a MRI like this? 4 pages of stuff. Plantar heel pain. And aches and pains from walking funny. I wouldn't think that aches and pains from a gait abnormality would lead to an MRI that's showing all of this. And once again, the MRI is sensitive enough to be able to pick up these strains in these tissues that are not symptomatic. But this is the magic of the MRI that you're seeing, is it's telling you a story about what's happening with these feet. There's her denervation. Now, look, we're going to be doing a plantar fasciitis surgery on her, clearly, and she's got denervation. So, of course, there can be a neurogenic portion for heel pain. So we had to get an EMG on her, and she didn't have a tarsal tunnel, a Tunnel sign on her exam. So, of course, we had to send her for an EMG, and it's normal. And it's my belief that the high arch that these people have, combined with the pronatory force because of the equinus, is straining the tarsal tunnel, and it's affecting the musculature in the foot in the innervation. And I'm not making this up. I'm going to show you some proof. This explains the denervation of the intrinsics. Here's my humble thoughts on the matter. These feet are anterior cavus, and when you look at these, you have to immediately start thinking about this. And this explains lateral ligament because they're always kind of bumping lateral, and their peroneals are always trying to evert that foot. But there's no history of ankle sprain. But they have pronatory forces because of their equinus. And that's leading to posterior tibial overfiring and midfoot OA. How much can a cavus foot pronate? It can't. Can't really. But look at the strain you're putting, right? Think about this for a second. Remember I asked you to think about that, look at the compression in that anterior ankle. What's the widest part of the talus? It's anterior. Well, what do you think happens when a cavus foot structure that has to dorsiflex and burn a little bit of ankle flexion and puts that widest part of the talus underneath the mortise, and then they need 5 to 7 more to get walking, if it's 5 to 7, and they don't have it? What do you think happens to that load underneath the ankle joint? Well, here's MT again. Look at this. Mild to moderate edema of the anterior tibiofibular ligament, posterior tibiofibular ligament, interosseous tibiofibular ligament sprains. This person is not a rugby player. She didn't have a high ankle sprain. Why is the MRI showing this? Well, it's because of the pseudoaquinus. What's going on with the TN joint? Think about the major mover in the rear foot. It's not even the subtalar joint. It's the talonavicular joint. What do you think the shear is on a TN joint when a cavus, anterior cavus foot type has to dorsiflex, burn whatever little ankle dorsiflexion it has, and now it's hyperpronating with every step, rocking from a little bit of a high arch to a little bit of a pronated arch? Imagine the bending moment on that joint. Well, look at these feet. You can get a little bit of talonavicular irregularity. You can get more. You can fracture a piece off. That thing is shearing back and forth. It's just, I'm sure you picturing what I'm talking about? This thing sliding back and forth and shearing. You're getting contact on that superior aspect of that joint, and it's making these changes. It's a gait abnormality, everybody. That's got an ICD-10 code. There's perineal pathology because these are cavus feet and they're trying to evert. And then posterior tibial tendon pathology because they're trying to resist pronation. And then anterior tibial is overfiring to supplement for equinus. We know this. Doesn't posterior tibial tendonitis show in a pronated or flat foot condition? All of these had posterior tibial tendonitis. Now, we didn't see SB, our one in the middle with 3 surgeries, but look at these feet. Would you think that if somebody showed you this x-ray on a lateral view, would you think that PT tendonitis would be your first thought? What are you going to do, a flat foot recon on these? Right? A calc osteotomy? This is what people do. They see these MRIs and they start opening people up and they fix their PT tendon and they fix those perineal tendons. I think this is the thing, we're missing the boat with these. Tibialis anterior and the extensors are firing to aid in dorsiflexion. And what happens is it ends up inverting more and it leads to overfiring of the perineals to counteract that inversion. And that's why the perineals are acting up. That's why they're fraying. How do we know tib anterior gets problems from equinus? Well, when you do a gastroc recession, tibialis anterior insertional tendonitis gets better. This is John Anderson from Grand Rapids. Yeah, when you have adequate ankle dorsiflexion, that guy's not firing. They didn't touch tibialis anterior here. They lengthened the posterior group. How do we know equinus fixes midfoot overload? Well, there's a beautiful systematic review. I showed this in my Bauman lecture. And they broke it down into different parts of the foot. And when you look specifically at the midfoot, forefoot overload section, even though they couldn't give it an A because there's not a ton of studies, they gave it a grade of a B, which is fair evidence to show that when you lengthen the posterior muscle group, forefoot and midfoot overload symptoms get better. And we know that gastroc recessions treat metatarsalgia. Here's a great article. These guys are outside of Philadelphia. They gave people with midfoot arthritis an option to simply have a gastroc recession instead of an arthrodesis. Now, it's not a massive number, 11 patients, 13 feet. And I wanted to see what was the severity of arthritis. Were they just looking at very mild arthritis? Well, in the inclusion criteria, you could see this little thing. There's a men's score. What does that mean? So I pulled the men's article. And a men's 2, and they didn't operate on less than a 2. And this isn't a midfoot, this is a first MPJ, for example, but it's moderate to severe arthritis. They only operated on 2s and 3s at the second and third tarsometatarsal joints, and that's moderately severe to ankylosis. So this wasn't just some dinky arthritis at the midfoot. Everybody had a Baker. If you remember, the Baker's a tongue and groove. Just a reminder, I don't do them, but it's a gastroc recession, right? 8 of 11 patients responded. Once again, not a massive N, 12 to 40 months, but here's the thing. Nearly a 50-degree point AOFAS score improvement. Nobody had an arthrodesis, and they all would recommend gastroc as an alternative to midfoot. And who wouldn't? There's a massive change in the post-operative course for patients with a gastroc versus a midfoot arthrodesis. Why are we doing all these tendon repairs when we're addressing the root cause? And I'm going to show you a case at the end of way too many, a patient that had massive misses. This is the root cause. All right, we're seeing this. You have to hyperdorsiflex that ankle because not only do you need 5 to 7 maybe for normal locomotion, but you need to burn 3 or 4 to get that forefoot to the ground. How do we know that pronatory forces and equinus cause denervation? Am I just making up that that's what happened to the intrinsics? My patient had a no Tinel sign. She had a regular EMG, no issues. Well, look at this paper. Cavus feet and pronated feet cause tarsal tunnel. And here's why. The volume of the tarsal tunnel changes when there's inversion or eversion compared to a neutral position. And if you leave an inverted or an everted foot for too long, and these are going from inversion to eversion and back and forth, enough to shear the superior aspect of the TN joint, what do you think happens to the flexor retinaculum over that nerve? It explains the forces and the denervation of the foot without overt tarsal tunnel, and it's going to come if you leave it alone. There's too much strain. You're going from an inverted position to an everted position. Both are bad for tarsal tunnel volume. Here's that SB patient. She's a really sharp lady. When she was 13, she had a flat foot surgery. And she had a Kidner, she told me, and she knows the procedures. She's a smart gal. And it didn't do enough, so when she was 15, they added a calc osteotomy on that side. And then when she was 16 or 17, and I'm using air quotes, you can't see me, the technology improved. So she had an arthroresis on the left side with a Kidner. Here's her foot, and this was done in 2000. They added this in 2002. I personally don't think she had a flat foot. You starting to see this now? I think she had an MRI that was showing all this stuff and people thought she had a flat foot. I don't think you can, with a Kidner and a calc osteotomy, make a cavus foot like that. Maybe, but I don't know. I don't think she needed these. Here's her other foot. Technology was better, she got told. I think this was a miss. Despite all that surgery, she had flat foot reconstructive surgery. Can you guess what procedure she didn't have? I think you're guessing now. She didn't have a posterior lengthening on either side, which to me is insane. If you're doing flat foot surgery, folks, if you're somebody that has, the training and the certification to do this, and you're, in my humble opinion, if you're not doing a posterior lengthening, you shouldn't be repairing these feet. Unless, of course, there's no equinus. And how often is that? That's the driver of a flat foot. It doesn't happen very often. You don't have to do an intramuscular if you don't, want to do a Baumann. It's fine if you want to do EGRs or whatever. But listen, if you're somebody that cuts calcanei, I think that's the plural, and you're doing tendon transfers and you can't do this, because these people are going to be in a cast. You do a calc or a double calc and a cotton or whatever you're doing, flexor transfer. If you don't do this, you get out of the flat foot business. That Hulk right there, I think it's the Hulk, right? The triple hemisection, that takes 30 seconds. Now, of course, a gastroc is not the fix for everything, right? Here's my patient. You all know how I feel about bad bunions, and this person had one. The bunion wasn't her issue. There's that little lesion marker. She was painful at the spur on the top. And once again, this is not just for the, here's the thing. That paper showed that these got better with a gastroc. She had a spur. She had no cartilage. So I did a second TMT fusion on her. And I did a gastroc. And it fixed her. And then she tells me her bunion feels better. And it looks better. I'm like, I didn't touch her bunion. Her IMA got better after the gastroc. She wasn't loading her forefoot. I literally decreased her IMA by 4 degrees. It's still bad. But she noticed it. She told me. Interesting note about second TMT arthritis. There's a wonderful paper years ago in JBJS, and if the first is short or if the second's long, you get isolated second TMT. I'm not going to belabor you can think about how that is, right? If you got a short first, you're loading second more. If you got a long second, you're loading second more. And that's what the conclusions show. So can it help your treatment? Well, yeah. If you do a while osteotomy, open or minimally invasive, second TMT arthritis gets better. These people had a DMMO, not for metatarsalgia, for second TMT. And they all had improvement. And it's a minimally invasive, safe procedure for lesser TMT joint arthritis. And if somebody can't have potentially a amount of time off their foot, my opinion would be that this open or DMMO type while, along with a gastroc, might completely eliminate the need for a second TMT arthrodesis. And the data shows it. Here's our 5 patients again, everybody. Here's KB. She had issues in the midfoot, diffuse discomfort, and her perineals, of course, you could see on the right side. There was a little bit of issues with the perineals. She could not be off them long. I injected them with PRP, and I did a Baumann, and it nearly fixed her. This foot used to give out. I'm still doing some sclerosing on the perineals, and her foot doesn't give out anymore. And I know I've talked about sclerosing previously, and people have called me about sclerosing. They do it in patellar tendons. It's not some bunk science. They do it in olecranon tendon in the elbow. Here's 2 Achilles, and I inject Achilles all the time with sclerosing. You can't put cortisone near the Achilles, and people do. I mean, that's if you rupture after an Achilles corticosteroid injection, you might as well hand your keys over because you're going to lose that case. They even used to do it in horses. I found this article. Sclerosing agents in tendon repair. And here's what you get paid for sclerosing. Now, this is my 64632 code. I had my biller pull this. But look, 2020 was COVID. I didn't give a whole lot, and still dehydrated alcohols a lot. And this is tendons plus neuromas. But look, one code. Look what it can give you. I mean, this is all legitimate stuff. It's not, this lecture isn't about monetary things, but here's JB, right? This was the second, the moderate to severe NC. She had a gastroc recession alone, almost fixed her. We're still sclerosing the tendon, and I did one extra thing I'll talk about now, but here's that incision. Remember that anterior cavus foot type. Some of these get a little necrosis like you see on the left, but there it is, healed up. And these need extrinsic support. You can't just do a gastroc, and these people, when you put them on the ground, you can slide a golf ball under their arch when they stand. Maybe not a golf ball but they have a cavus foot. You need contact under that arch. And I don't know why people use the same damn orthotics for flat feet and cavus feet. Cavus feet are rigid. You cannot put a rigid orthotic under them. I don't know why people put this type of an orthotic under cavus feet. You need this. This is sole support. I'm not a spokesman. I don't get paid from the company. But if you don't use sole support or one of these flexible full contact orthotics, look at the arch on that. You can't beat it. She's so much better. I took the pronatory force off her foot with the gastroc. Now she's not pronating into an orthotic. We're working on that tendon a little bit more. She's nearly fixed. She didn't need an NC fusion. Here's our 2 flat foot reconstructions, right? She had a gastroc on both sides and she's done. She's discharged. Midfoot pain gone. I just did the Baumann on our other patient. We're going to see how that does. I don't have an outcome yet. But she had a MRI that wanted to show fit in with everything. Here's MT, right? Here was the thing. What are you going to do to this patient, right? She had plantar heel pain. And she had an over 6 millimeter thickness of her fascia. And that's the at 6 or greater on an ultrasound is when I add an instep. And I fixed her. Now I had to slide the gastroc around this tattoo in her leg. There's her instep. Had to plan that carefully. I texted with her the other day to get some pictures updated. Here's her instep fasciotomy. You don't see it. How you doing? That's her text. I'm doing great. I love to see that. That's the caffeine molecule. You could tell she's a caffeine drinker. I'm right at 30 minutes. I'm going to go just a little over because I wanted to show you these slides. But here's my good friend Stephanie Carollo sent her over because she knew she needed a gastroc. And Stephanie got this MRI and she did the right thing. And we got an EMG on her, and this was that negative tarsal tunnel, making sure there was no neurogenic heel pain. She had surgery on 8/13, sutures out on 8/26, and she had a follow-up on 9/8, and she was feeling a little under the weather, and she canceled, but she was asymptomatic. And that was 91 days from when I met her and 26 days from surgery. Who could think with an MRI like this that you can get a foot better like this in 26 days? It seems impossible, but it's not. She's done. We know that people with more foot pain have a tighter posterior group than people with less. And you need a radiologist like Reza Sezgari, who's going to lecture this weekend, I think, to read this for you, because in a minute I'm going to show you some MRIs, and somebody didn't read an MRI like this, and you could tell it would look like this if Dr. Sezgari read it. But it was just one of those we never looked things. But I need this stuff to tell me what I need to do. Make your patients go to Basha or somewhere where he reads. And if you're somewhere else, you gotta call him and ask him who does what he does, because he's amazing. Two patients I'm going to close with, and these are new, so I wanted to stick them on the end of the, it was a late edition. But RM, she had 2 surgeries. She got referred by a local family doctor of mine. She underwent a PT repair by one of my colleagues, and then she had a tarsal tunnel by Dr. Manoli. I didn't mind throwing he's not with us anymore, but he didn't like podiatry very much, but a world-renowned foot and ankle surgeon. You see, are you catching my drift here, everybody? PT tendon repair, tarsal tunnel. Guess what surgery she didn't have? Here's her just recent MRIs. Now, this is not a Sezgari MRI, but I could tell that it would look exactly like that. We just didn't look at anything. We just looked at the problem when they said posterior tibial tendon and Achilles tendonitis. It would exactly look like that. Those muscles would be denervated. She didn't need a Achilles repair. Here's her left. Posterior tibial tendon repair, excuse me. But here's her left. She's got less symptoms on this side. Here's her foot. Does that look like a foot that needed a posterior tibial tendon repair? That's cavus. That's a bullet hole sinus tarsi if I ever saw one. Posterior spur, John Harris. Here's her other side. John wouldn't have seen this. Look at those spurs. Here's her right side. Catching my drift? Here's her 2 incisions. Potential surgery that didn't need to be done. Now she needs another. There's her right. Can't get her to 90 on the right because she withdraws. That's as far as I can get her on the left. She needs a gastroc bilateral. Most tarsal tunnels need a gastroc potentially if Aquinas is present. It's my humble opinion. This is my last thing. This patient came in with another patient of mine. I just did a first MPJ fusion on her best friend. And my first MPJ fusion post-up was on 2-4. And this lady came in and she drove her. And she's sitting in the back chair and I'm seeing my patient. She's like, do you do second opinions? I said, yeah. She says, I've had 18 surgeries on my feet. You counted that right. 18. She got problems with her left Achilles. Her last surgery was a 10X on her Achilles. And so I literally took pictures of her feet that day, had her take her shoes off, and I looked around. And she was having an upcoming MRI, and I told her to get it read at Basha Diagnostics because I knew they were going to give me the information that I need. Perineal repair on the right, tarsal tunnel syndrome bilaterally, Baxter's nerve repair. Are you seeing, you getting the drift here? Here's her foot. Here's the tarsal tunnel incision and the Baxter's nerve repair on the right. Here's the lateral right, perineal repair and an exostectomy at the 5th metatarsal base. And I don't know who in their right mind would do that. This is not a problem with the bone, everybody, at the peroneus brevis. This is an overfiring of the brevis. You need to take the pressure off there. Look at the bulge in her Achilles on her left side. Sorry about the blurriness. There's her tarsal tunnel. In my opinion, could have been avoided. There's her Achilles. This just had a tenex on it. This is post-tenex. That is not a tenexable Achilles to me, in my humble opinion. And here's her foot. Cavus. Here's her most recent MRI. And I'm going to go through this really quickly, but she's still got PT issues. This was 2015. She had a midfoot loaded on her left midfoot on a bone scan, and that would have clued me off immediately. But no, what happens? Well, she's got neuritic symptoms. She had a tarsal tunnel and a perineal PRP and on the left, and I do that, but once again, missing the boat. There's something causing this that didn't get addressed. Another MRI. Now we're going to release her tarsal tunnel on her right. This is just a couple surgeries. Another MRI, 827, she's not better. And then Baxter's nerve neurectomy, Achilles tendon repair debulking, of course without a posterior lengthening, which that's crazy, and a plantar calcaneal spur removal for plantar fasciitis. What's the main surgery for plantar fasciitis? It's a gastroc. Did it get done? No. That got added right at the end. Oh, fix my plantar fasciitis. Different writing. That's how we know. And by the way, don't do a surgery the day after you do a consent. Let your patient think about what you told them for a day or two. That's a bad idea in my book. Consent 118, surgery 119. Another MRI. Still problems with the Achilles. So she had a bunion, and now they did the posterior calcaneal exostectomy. Haglund's. No lengthening. Nuts, in my opinion. Things better? No. Another MRI. Anterior syndesmotic ligament. Are you seeing this again? Thickening of the Achilles. Let's go back to that. Perineal tendons. Posterior calcaneus. Even plantar fasciitis issues. I thought we did a plantar calcaneal spur. They're seeing a medial band of the plantar fascia. I guess, now you can see the doctor's just missing. I don't know what the hell they did. How you take a plantar calcaneal spur off without detaching the plantar fascia is beyond me. Another surgery might help, though. The bunion didn't get fixed all that well. We're going to add an Aiken. Now we're going to fix. Here's the exostosis resection of her 5th met base. We're going to fix ATF and CF. We're going to do a tenex on the tendon. We're going to take out some branches of the calcaneal branches. What the hell? Fix her perineals. A lot of resident training in all these cases. I'll tell you, these residents are happy. Everybody saw her. Continued pain. How about another MRI? Well, finally, Dr. Cesgari to the rescue, because he read this one. Look. Perineals. Posterior tib. Anterior tib. Lateral ligaments. Distal tibiofib. Achilles. Plantar calcaneus. Denervation. Lateral chondral narrowing of the talar dome. We talked about what happens to the ankle. Another MRI. And then another. And you know why this one has mild posterior tibial tendonitis? She don't walk right, everybody. She's got an antalgic gait. She's not using her PT. She had resolution of previous posterior tibial tenosynovitis. It didn't get better. She's not walking. I can't get her to 90. This was a joke, all this stuff. Missed. Another surgery. MRIs. Come on, give me a break.
When you're on?
Come on. Needs a gastroc on both sides. And now I have to debulk her Achilles because it needs an open repair. So anyway, I hope you got a little bit out of this. I'm 10 minutes over. I'll make my hammer toe lecture a little shorter, but this is really important because hammer toes are important too, but we're doing improper surgery on these patients, and they need the root cause fixed. And I thank you, and I'll end there. I hope to see you tomorrow, and we'll talk a little bit more in person.